Okay. Okay. So we are going to end the poll. Thank you so much. I'm going to share the results so that we see. You see in orange, that's the leader. Not necessarily that that's correct. Dr. Naeem will tell us that most people feel it's actually anxiety, but there's some people that feel it's actually brief psychosis. I'll be honest, I'll probably vote B as well. It's quite stressful to have COVID going on around.
Okay, all right. We'll move on to the second objective of the session, which is supporting individuals in isolation and quarantine. So as healthcare providers, how do we go about supporting individuals who are going through all the consequences of COVID-19? This is a slide that looks at two perspectives. The first one, if you look at the left side, which is the biopsychosocial, this was a blog written by an individual who stayed in ICU for a very long time. And I quote him, "The medical support keeps me alive, but it is the psychological and social support that enables me to live." The severe acute respiratory syndrome epidemic in 2003 was associated with the following responses. 29% of healthcare workers experienced emotional distress. 30% increase in suicide in individuals who are 35 years and older. And 50% of recovered patients remained anxious. And these were the group that were at risk of post-traumatic stress disorder and depression. Now, this is important for us to understand because it is not just individuals that we're supposed to support, but even as healthcare providers, we need to make sure that we are keeping ties in our own well-being as well. What does this slide tell us? This slide allows us to understand that with COVID-19, there is an acute stress reaction that individuals are going through even before they seek healthcare. Any individual who comes to the hospital, even in the absence of COVID-19, before COVID-19, individuals coming to the hospital were still feeling anxious and stressed. But with COVID-19, the story is different because this is a new disease and there's a lot of misinformation amongst us. This brings us to the understanding of what psychosocial and psychological first aid is. In 2016, the World Health Organization came about with the concept of commemorating psychological first aid in crisis management. This was important because it allowed healthcare workers as well as individuals who are looking after people in crisis situations were able to cope with them and were able to provide support to them. Turns out there are many, many individuals who are in isolation and quarantine who do not want treatment, not because they are, for lack of a better term, difficult patients, but because they are in themselves feeling anxious. So psychological first aid is something that helps individuals feel safe, connected to others, calm and hopeful. It has access to social, physical, and emotional support, and it also gives individuals that sense of control by being able to help themselves. Remember, these are patients who don't have friends and family at the bedside at the moment. These are individuals who are equally feeling and concerned what is happening back home whilst they are in quarantine and in isolation. So just like triage, where we have first aid in physical health, this also helps us identify the vulnerable population who require more support when it comes to their psychological aid and mental well-being. So now, what do we mean? What does that mean for individuals in quarantine? They are associated with social and physical distancing measures, which is leading them to have risk factors for mental health issues. And these include, in our setting, alcohol and substance misuse is the leading cause of admission when it comes to mental well-being. Because of isolation and COVID-19, there are many individuals feeling like a burden. This is leading to child abuse. They have lack of meaning, which is leading them to consider harming themselves, which is suicide. There is also domestic abuse that has been reported. And for those who are taking use more of social media and the digital use of internet, they are falling prey to gambling. And of course, there's also digital use with cyberbullying. But let's talk about the psychosocial risk for a second. There's financial stress, there's bereavement, there's loss, and there's homelessness in the low socioeconomic class. This is leading them to have anxiety and may predispose them to have a mood disorder, depression, as well as post-traumatic stress disorder, which may ultimately complicate to self-harm and suicide. So now let's talk about mitigating stigma associated with COVID-19. we need to understand is that we need to have a right balance between basic needs and COVID-19. There are basic needs that need to be met, which are the psychological needs, which is food, water, warmth, and rest. This is based on Maslow's hierarchy of needs. There are competing needs that need to clearly be addressed right now as we're preventing COVID-19. Achieving the right balance between infection control and mitigation of negative socioeconomic effects is needed should we want to mitigate stigma. Communication and information dissemination is required for mitigation of stigma right here in Zambia, in our population. Let's talk about our communication measures that we have put in place. We need to understand that not everyone has access to media, not everyone has access to radio and TV, and not everyone understands English. Everyone needs to have their own tailored response when it comes to communication of information with respect to COVID-19. Also, frequently asked questions need to be answered in the vast infodemic. What do we mean by infodemic? Dr. Tedros from the World Health Organization says that we're not just fighting an epidemic of COVID-19, which is now a pandemic, but we're fighting an infodemic. There's a lot of misinformation out there. The stereotypes and myths. For a lay person whom you're going to tell, please clean your hands with alcohol-based hand sanitizer. For that person, alcohol means to jili, it means kachasu, it means beer. So they will clearly say that, can we use to jili or kachasu to wash our hands? Because you're saying alcohol-based hand sanitizer. This information needs to be shared if we want to help with good information in our own communities. So there needs to be strategies to help individuals to stay informed by authoritative sources, prevent overexposure to media for the middle class and upper class who have access to social media and all the other media outlets, and mitigate and help manage the effects of viewing images with traumatic content. Remember, for a country like Zambia, the swabs that we're doing for COVID-19, which is in the nasopharynx, that is actually a traumatic content that we cannot easily show in our media. If we're going to show this in our communities, it's going to create panic and alarm rather than do good. These are things that we need to understand when it comes to stereotypes, myths, and mitigating stigma in our communities and in our population here in Zambia. Next slide. This brings us to the second poll question of the fellowship.
How can you promote well-being and stay informed about COVID-19 through traditional media and social media on mental health? Is it A, stay informed by repeated media exposure to information about COVID-19, especially through informal social media networks? B, stay informed by authoritative sources, prevent overexposure to media by limiting access to media updates. C, stay informed by social media and word of mouth. So we are soon going to launch the poll. There we are, single best answer. What do we think? How can you promote, well, oh, there you go. How can you promote well-being and stay informed about COVID-19 through traditional media and social media? At least 6% of us feel that we should stay informed by repeated media exposure to information about COVID-19, especially through informal social media networks. 87% of us feel that we should stay informed by authoritative sources. We need to prevent overexposure to media by limiting access to media updates. Please stay informed by social media and word of mouth. Please feel free to poll. We only have about half of the network polling. We need to know what you think so that there's a two-way form of education. But I'm sure you can see that, Dr. Naeem, some people strongly feel that we need to keep on looking. If you haven't found it on Twitter, you need to go to WhatsApp. If you haven't found it on WhatsApp, go to Facebook. If not, phone your friend who works at UTH. Like, keep yourself abreast, because maybe people do not trust the information that we are giving them sometimes. Maybe that's why they want to look for other sources. But I'm sure you tell us more I will share how we have polled. So at least 84% of the people say that you should look for authoritative sources. I believe by authoritative, you are saying the World Health Organization, the Ministry of Health, ZNPHI, CDC. Well, some people feel that you really need to look for it out there so that nobody lies to you, I guess. We'll hear them answer later.
So now we come to the communication with healthcare workers, psychological care of healthcare workers involved in COVID-19. As healthcare workers, we are at a significant risk of adverse mental health outcomes during the COVID-19 outbreak. Reasons for this include long working hours, risk of infection to self, shortages of protective equipment, loneliness, physical fatigue, and separation from families. Now, excluding observational studies, all from Chinese centers have addressed this topic. And one of these papers actually illustrates the gap between planned services at a given hospital and the actual needs of healthcare workers. We need to understand that we are a vulnerable population when it comes to mental health with respect to COVID-19, because there's fears of contamination, and coupled with long working hours leads to the concerns that what happens to my friends and family should I get infected? What happens if I am not able to take care of a particular patient in isolation? Who is responsible for COVID-19? Is it just the ID specialists, or is it a community effort when it comes to healthcare workers? Who are frontline workers and how do they work? Turns out, because of the medical journey that we go through in our respective health studies, we come up with a very strong resilience pattern as healthcare providers. We do not ask for help. And this is because of the training that we go through. And so our resilience patterns, our ability to bounce back from stress is usually tested, and we have a better resilience pattern as opposed to the general population. But because of the severity of this pandemic, our resilience patterns are being tested right now, because our coping strategies, such as going to friends and family right now, is being tested. Our shifts have been divided, our workload has been increased, and there is that concern. The other reason why healthcare providers often do not ask for help is due to confidentiality. So the need to make sure that whoever I am reaching out to is not going to share the information that I want to talk about. But the other concern is, how do you go about dealing with the psychological care of healthcare workers right now? What is very important is preparedness and training. The COVID-19 response training is very important so that healthcare providers know what they are dealing with right now. Adequate PPEs has been highlighted here because it's not just a one-off thing. There needs to be a steady supply of PPEs. The isolation centers need the PPEs, as well as all healthcare outlets right now, all hospitals need PPEs, adequate supply of PPEs. This, we can give an example of Chilinge, we can give an example of UTH, where these are not isolation centers, but everyone is a suspect for COVID-19 in hotspots. Also, information and communication. This is very important because as healthcare workers, we are key stakeholders in this fight. So we need adequate information coming in our way. This helps with the anxiety and the stress with fighting COVID-19. Motivation and incentives, risk allowance. Remember, all the vulnerable populations that we mentioned, as well as the consequences of COVID-19, equally, we too have those consequences. We too have friends and family who we are looking after. Should we be in our health work environment for a long time, we need to know that our friends and family are well looked after. There are parents amongst us, there are dependents amongst us, and all of this comes from that motivation of incentives. Also, turns out studies that have been done in Asia and in Europe so far, in Asia, in China, healthcare workers were stressed not because of COVID-19 itself, but they were stressed because of the consequences of COVID-19 in their personal lives. As you're aware, the economic challenges are also going to be faced by us as healthcare workers. Also, what is the best way for you to be vulnerable enough for you to ask for help? There needs to be personalized psychological approaches which are likely to be a key component in addressing moral injury, coping mechanisms, and prevention of COVID-19. Another thing, with your long shifts right now, you are not taking care of your mood, your sleep, and your appetite, which is very much needed for you to have that strength and a strong immunity for you to fight. But if you're not going to have your shifts well scheduled, and if you're not going to make sure you look after your sleep pattern as well as your diet, you are going to weaken your immunity, and this is going to make you be at more vulnerability when it comes to COVID-19. What is being implemented and proposed all over the world, and that should be the same here in our country, should be the promotion of debriefing on cases. Debriefing of cases basically means what we are doing in our treatment of our own people. It needs to be shared. And we also need to have what we call vulnerability circles. This is where there needs to be open spaces where people can talk about their stressors and be open enough to share the experiences so that others can learn from one another. Right now, despite the fact that we do not ask for help, this is the time we need to ask for help. Next slide, please. So interventions and recommendations overall from the various objectives that we mentioned. We need to understand that mental health is recommended in the forefront of the pandemic mitigation. World Health Organization psychological first aid training to all first-line respondents, healthcare workers and allied professionals such as individuals in the security wing need to be taught psychological first aid. Use of simple tools such as the Hospital Anxiety and Depression Survey, as well as Strengths and Difficulty Questionnaire, perceived stress score tool for the wider population can be used to generate psychological needs and guide intervention in our country. Other interventions that can be used are art-based interventions. We also need to generate activities that boost positive coping resilience throughout societies, and also community-based activities from life skills coaching to life skills classes. These are things that are currently taking place in our country that need to be used right now as we're focusing on the COVID-19 response. Now, the effectiveness of the intervention requires rigorous evaluation because we don't want to start saying do this and do that. We want to have evidence-based based on our communities here. As you're aware, we're not that many in the mental health field. This is where we can use telepsychiatry as currently the hub is being used. Telepsychiatry and therapy to aid in psychosocial training and interventions. This is something that the mental health team, the wider mental health team can help, not just you, the healthcare providers, as you cope, but also the wider population that are more vulnerable as you treat them with COVID-19. So this is a regional practice. This is a consideration. Ministry of Health, Republic of Ghana, have introduced the psychological first aid, the World Health Organization psychological first aid in their COVID-19 response. As they're carrying out their triage in outpatient departments, as well as quarantine persons, as well as healthcare workers exposed, they are promoting this model. What they're doing is for suspected cases, they are giving the psychological first aid. And for positive cases, they are promoting telling bad news. This is the art of telling bad news. What is it that you can share with this patient and what you should not share? The next slide, please. And for those patients that test negative, the community is actually being shared. Psychological first aid is being shared in those communities to help mitigate myths and stereotypes as well as stigma that is arising from those communities, so that everyone comes for help when they have to. Thank you.
Thank you so much, Dr. Dalal. We'll allow people to make comments, any questions for Dr. Naeem. But as we do that, we'll ask Chatonda to take us to the reflection slide. I'm sure he would like to comment on that because I'm like, gosh, this 30-year-old is having a heart attack. Chatonda, please share the reflection slide as we take any comments. I can't see any hands, but you have a lot of chats as expected. Let me know if there are any hands on that.
Okay, so coming back to the reflection slide, and this was a case that Dr. Sombo came across. Now, the point that we need to understand is that anxiety is the #1 response in a pandemic. Everyone is going to feel overwhelmed, and this is not anxiety, that is a full-blown mental health disorder. Anxiety is a trait that many people will go through, and there is a concept of health anxiety that comes about with hospitals and clinics. Health anxiety arises from a misinterpretation of perceived bodily sensations and changes. It can be protective in everyday life. However, during an outbreak such as this with COVID-19, in the presence of inaccurate or exaggerated information from the media, health anxiety can become excessive. At an individual level, this can manifest as maladaptive behaviors, such as repeated medical consultations, as this was the case with Dr. Sombo's patient, avoiding healthcare even if genuinely ill, and hoarding particular items. At a broader societal level, health anxiety can lead to mistrust of public authorities and scapegoating of a particular population or group. And this brings us back to our first poll, where we asked what is the main emotional response that you would expect in a pandemic. Anxiety is the leading one. That doesn't mean that a brief psychotic episode or anger will not be one. Remember, brief psychosis comes about when acute stress is not overly well equipped and handled. What I mean by that is, with day-to-day stressors, you are going to cope. But when they become chronic and overwhelming, there is a high probability that you are going to have a break in your reality, and this will predispose you to brief psychosis. This is not very common, but with the nature of the stress that COVID-19 is predisposing individuals to, there is a high chance that they may end up having brief psychosis. But anxiety is the #1 leading emotional response. Anger is also a response, but this goes through stages. Anger, denial, bargaining, all these are responses, but the #1 cause is actually anxiety.
So what's your diagnosis here?
So this is health anxiety.
Okay.
All right, in this case, this is anxiety response, acute stress reaction, and this person clearly would benefit from psychological first aid.
Okay. Not from chloroquine, azithro,
No.
not from ventilation.
No, not from chloroquine, not from azithromycin, because this is a person who clearly has access to a lot of information, and they constantly are reading, and the more information that they're getting, the more they are feeding into their anxiety.
Okay, thank you so much. I want to welcome other people that have joined the network. Just to mention a few, I've seen P.S. Malama has actually joined this session. I've seen Dr. Lekani, who's also a psychiatrist. I've seen Dr. Jerita Chinyonga. I see Stanley Zulu. Please feel free to ask if any questions. I want to ask Mutinta to please unmute herself and go ahead with the question. I know Dr. Mubiana, you have a question. Please prepare to ask. Let's stop sharing this one.
Hello, Dr. Dalal. It's Mutinta here.
Hello.
Yes, I'm glad you spoke about the issue of telepsychiatry, because I'm here at the center and I felt that a psychiatrist or a psychologist or a counselor would come over, but seeing that you're very few, like you mentioned, do you have any plans to have sessions using the media that we're using right now, like Zoom? That's the question that I wanted to ask.
Thank you. So this is something that we are discussing through our National Mental Health Coordinator, Dr. Siwo. She is in talks with the team here, as well as the team is also going to introduce psychological first aid for healthcare workers in the COVID-19 response trainings in the weeks to come. Also, the individuals at the isolation center will have access, should they need any support, to the team of mental health that will be guided by the Ministry of Health. But yes, that is a possibility, and that is something that we are working on. And this is the start. This presentation is actually a start to that.
Okay, I hope that's okay, Mutinta. Is that clear? Is that okay, the response?
Yes, it is, Doc. Thank you so much. Thank you.
Why can't we use the ECHO platform to be giving this type of support to both the healthcare workers and the patients that are admitted. I think Dr. Mubiana, please go ahead with your comment or contribution.
Hello, thanks for the presentation. I just wanted a brief on what exactly is involved in psychological first aid. I don't know if it was mentioned and I missed it.
So psychological first aid is a basic tool, just like triage with first aid in physical health. This allows you to look, listen, and link individuals with their underlying stressors. What that means is, for instance, in the case of COVID-19, where you're treating a person with COVID-19, not that they don't want to be treated for COVID-19, but they have underlying psychosocial stressors that they're focusing on. For instance, they're worried about people at home, they're worried about their job, they're worried about other securities for them. So with psychological first aid, what you do is you promote empathetic listening. You're not providing advice, you're just giving them a space to communicate. And as you're giving them that space, you give them feedback with grounding techniques of anxiety, how to cope with that. And that is the basic of psychological first aid in the immediate interim. A few people will be at more risk of requiring it, and this is why psychological first aid works right there and there. The good news with psychological first aid is nobody has to have a basic background in mental health. No. Any individual can actually offer psychological first aid provided they go through the training.
Okay, thank you so much. Wantula, do you want to go ahead with your contribution or question to Dr. Dalal?
Hi, Dr. Dalal, Wantula here. My question has to do with, I noticed you did showcase a bit of some tools that have been developed by WHO, and knowing that some of the evidence we're using is really not ours, I sort of look at it as an opportunity to be able to garner some evidence locally to really understand the burden that we're facing, particularly among health workers as well, the mental health burden as well. Perhaps, I don't know, maybe is that something that you're planning to do or doing already? Secondly, I know there are some risk assessment tools that will probably be beneficial in assessing who's higher at risk, perhaps amongst those that are going into COVID treatment center, sort of risk, screening out to on those that are higher risk in developing a mental illness, being screened out and not probably being recommended to go and work there or something like that. I'm not sure if there's some tools like that that could be sort of used to assess that. Thank you.
That you ask that first question, you are a bit woolly, so I will repeat. I think his question was, have we done anything in the local setting in terms of stress and assessing? His second question is the Ministry of Health, this may be a bit difficult because it's a bit policy level, screening out these people that are vulnerable to mental health conditions. So I think you can go to the slide deck.
All right, okay, thank you for that. And yes, World Health Organization actually looked at it from all the different regions, all the various continents, and this has also been used in the Ebola outbreak right here in our neighboring countries as well. So psychological first aid has been implemented, and it has actually been shown to say that it would work here as well, and we are carrying out surveys. But then on the tools that I mentioned, hospital anxiety tool, as well as perceived stress tool, these are things that we're using. And before coming to this presentation, we thought that we should do the same. So we actually did a perceived stress scale survey for Zambia to identify these populations. Next slide. So this was just online to see people why they are. And this was just in the past 24 hours. We got these responses from the general population, from these different places. Next slide. So now, these were the questions that were being asked to them. What is most stressful to you, COVID-19 or the consequences of COVID-19 on your life? Consequences were actually explained to them as has been explained in these slides. Many of them said both, but a few said consequences of COVID-19. What this slide basically tells us is that as you're treating this patient who says that it's just the consequences that they are stressed about, they are not really, they are going to be focused about what is happening outside the center or outside effort when it comes to them. Next slide. here is the consequences of mental stress. 86% of the responses actually said yes, and none of them said no. Tells approach, and there is our own right here, that as well. Here, asked stress and anxious COVID-19. That's purely for COVID-19. 60% said yes, others said maybe no. This gives us an understanding what the needs of our population would be. And looking at that, majority of our clients are from Lusaka as well as Copperbelt right now. This kind of survey allows us to tailor the treatment and response for them. The next one. Coming to the healthcare workers, we also instituted a survey in the past 48 hours to the healthcare workers at the centers. And we had these responses. We had 10 responses, 2 physicians, 5 nurses, 2 EHT, as well as radiographer technologists. Next slide, please. So similar questions were asked to them, but for them, it was more of a perceived stress because, as I said, in Asia, in China, doctors, but they were stressed because of the patient's stress level. 60% said no. Really, right now at this very moment. But then we have to worry about the 3 and the 10. In the last month, how often have you felt difficulties were piling up so high that you could not overcome? Worried about other things other than what is happening in the interim, what they're in control of, which is treating COVID-19. 30% said fairly often, 30% said sometimes, and 10% said very often. This is very alarming for me as a healthcare provider in mental health, because I know that these healthcare providers, as they're treating, they're also overwhelmed. Okay, the next slide. In the last month, how often have you been angered because of things that happened that were outside of your control? Again, here, 30% said very often. This is of concern because these are healthcare providers treating individuals who are already distressed at the isolation center. And healthcare providers also need support and care. So this is just to show you an overview that we need to have tailored responses for our population here in our country. As you're very well aware that mental health is very broad, and we are thinking in that direction. And this is the final question that was asked to say, do you feel equipping you with skills in basic psychological first aid will help you better care for your patients? 62% said yes. So if those people, those healthcare workers who answered yes to anger and yes to saying they feel overwhelmed other than COVID-19 treatment, for them, this would actually be helpful so that they can work better for their patients as well as themselves. So this is the reason why we need to incorporate psychological first aid in our care for COVID-19.
I hope that answers your question. I do not know if you want to take up the question about advocacy with the Ministry of Health for people that are more vulnerable, because there are people who are more likely to keep because of mental health issues. Are we trying to screen them out? That's Dr. Wantula's suggestion. I'm not sure if it's the right thing to do, but do you want to talk about that?
This is why the first 3 slides were actually just bringing about the vulnerable population, and these are the people that we need to be more concerned about, because mental health is a chronic disease and we don't want our population, and if you look at the majority of the population in the low socioeconomic class, to tip into having full-blown mental health disorders. We cannot allow that to happen if we know this information right now. So it would be good to actually do that in our screening processes as well. And this is something that hopefully we will work towards as well, yes.
Okay. So I hope that's very clear, Dr. Wantula. I don't know, I've seen Dr. Lekani, if you would like to comment on that. But for now, we can do this poll and then you can tell us the answer. So how can you promote well-being and stay informed about COVID-19 through traditional media and social media on mental health? Should you stay informed by repeated media exposure to information about COVID-19, especially through informal social media networks? B, stay informed by authoritative sources, prevent overexposure to media by limiting access to media updates. C, stay informed by social media and word of mouth. Please, we would like our network to vote so that Dr. Dalal can know what to address, as you can see. Yes, thank you so much, but only 30 people have voted so far. We'll give it 30 more seconds to allow people. Okay, interesting. So C is now even coming up as an answer, as initially it did not. We still feel, some people still feel they need to get that repeated information. You know, you don't want to be left behind, isn't it? While some people say it's better to be informed by authoritative sources and prevent overexposure to information. So I'll end the poll and I will share with the network how we voted, and Dr. Dalal can now tell us.
Coming back to the presentation, we discussed the concept of an infodemic. The more information that you have, and this information that is not verified from sources, you are going to feel overwhelmed. And this comes back to our reflection slide, and this builds into the health anxiety. The best way and what has the best practice that has been forwarded by the World Health Organization, as well as all other countries, including Zambia, is promoting is stay informed by authoritative sources. This helps prevent overexposure to media by limiting access to media updates. This is very important because this helps you prevent those surges of anxiety and sudden stress attacks. But at the same time, if I would like to let all our people know right now is that C, which is staying informed by social media and word of mouth, is the actual thing on the ground right now. Everyone is getting access of information from social media, and through their networks, they are sharing information through word of mouth. As you're very well aware, sharing information through word of mouth gets diluted, misinformation and misinterpretation happens a lot. As I highlighted, using alcohol-based hand sanitizer. A person in a shop will listen to it out there. That person will translate it to say alcohol is moa, beer to jili jili. That is something that needs to be also looked at. Another thing with respect to anxiety is that if you're going to have access to all this information, you are going to have anxiety with respect to all the information coming your way. This is why right now there is that talk about hydroxychloroquine. Even before the studies have concluded, people are talking about all these measures that can be taken in. And this, for healthcare workers, is also very important. Please try and stay away from repeated exposure to media, because this will actually feed and fuel your anxiety.
And it's important that that information is from a reliable source. We don't want people injecting themselves or rinsing their mouths with insecticide. Another common myth that has been out there is just on the surgical mask. It's amazing. People who are physicians, well-trained, they're now turning the mask upside down because there's this lady on a picture who says if you work the other way, then you are trying not infecting yourself. There's only one way to wear a medical mask, the darker part outside. If it had those uses, they would have said it on the box. But I know that's one thing that has definitely gone viral. And of course, do not inject yourself with disinfectant. Patricia Tembo, please go ahead with your comment. I'm sorry I've kept you waiting for some time. I have unmuted you.
Okay, no, I think earlier on it was mentioned that tele-interventions might be available for healthcare workers and I think inpatients, but I was wondering whether then the kind of a wider population would be considered as well, because I think just sometimes it would be probably less risky and easier to just phone in terms of just trying to identify what's going on before you actually present yourself in person at a center. Because a lot of people do have telephones, mobile phones. So if you can phone in, maybe just, or if you're going through some issues, just to phone in, because I think he said it would only be, well, I think they were considering healthcare workers and inpatients earlier on. Did I get that right?
Yes, you did. I think it's a submission, more like. aware that ZMPH, the disaster management unit, and make it also capable of doing what she's doing. There is something from Ramya Kumar. My suggestion some of these myths about using beer and alcohol as that now okay. Actually sent through the network. We would like if any something can you hear us? He's not unmuted. How are you?
Fine, thanks. How are you? Sorry, I can't get you. The network is pretty bad.
Dr. Chanda, it seems the rest of us can hear you.
I can't hear. Hello?
We can't get you, please. Network is so bad.
Okay, can everybody else get me?
Yes, we can.
I can.
Yes.
Yes. Yes.
Yes, we can.
You now.
Okay.
We can get you.
Let's get started.
You can go ahead, we can get you.
Okay. Good afternoon, everyone.
Good afternoon.
Yeah.
I'm a registrar at a registrar in internal medicine, and this is a quick case presentation about a patient that we had at a facility, a COVID-19 facility, and basically highlights everything that Dr. Dalal has been trying to present. Next slide, please. Okay, so our patient is a male, 41, with a history of recent international travel. On his way back, he had contact with a non-COVID-19 patient on a plane. So on presentation, he had no complaints. On admission, the patient had been asymptomatic. So I was reviewing him on day 18, post his admission. So throughout his admission, the patient was asymptomatic, and he had a strong belief that because of his lack of symptoms, he was actually negative, and he was only being kept at the facility for financial gain. So he kept telling the staff that he wanted to go home, and as a result of that, he became uncooperative towards them. Subsequently, he even began refusing treatment. So the psychological assessment on the mood-wise, he reported to have been feeling okay, and identified as having psychosocial stresses. His sleep patterns, he said he had been having difficulties sleeping, an average of 7 hours. He actually was reporting that he would often wake up in the middle of the night at 2 and would have difficulties going back to sleep. However, his appetite was well. The review of systems, surgical history, family history was unremarkable. Past medical history, he was RVDR newly diagnosed 18 days ago, but he had no history of hypertension, diabetes, asthma. Current drug history, he was on TLD and isoniazid. Then he was not a non-smoker, and he was an occasional drinker. So on examination, patient was generally stable, not in obvious respiratory distress, no pallor, no jaundice, no cyanosis. He was febrile to touch. Then his BP was borderline hypertensive, but saturations were normal in room air. Mental state, appearance and behavior, he was anxious and irritable. Speech and thought was normal, mood and affect was euthemic, and perception, he had no hallucinations. The remainder of the exam was, however, normal. Next slide, please. So this represents the patient's results. His initial test, his initial workup actually revealed that the patient was actually HIV positive and also hepatitis positive. The other baseline investigations, the full blood count, renal function test, and LFTs and chest x-ray were normal. Then the routine PCR for the SARS-CoV-2 was positive on diagnosis, and then subsequent 7 other swabs done, which was at initial 3 days apart. Then later we started doing them weekly, were all positive. So what was done? Patient was initiated on TLD and isoniazid. Then patient was also isolated and put in and being managed symptomatically. Next slide, please. Okay. So would you label this patient as being difficult? Why do you think he was refusing treatment? And what would your next step be in managing this patient? So, to the first question, when I was receiving the handover of this patient from the previous group that was working at this isolation facility, this patient has actually been labeled as difficult. Perhaps we can come to the questions after. Maybe we can get the next slide.
Don't go to the next slide.
Next slide, please.
Yes. It's muted. Dr. Katauba. Sorry, we are.
Hello, Dr. Somba.
Oh, so you can hear us. Which device are you? Okay, we officially have speakers. I'll have to ask Naeem. And
No, mine is connected.
Dr. Steve, Dr. Chanda, can you hear us?
Yes, I can hear you.
Oh, thank you so much. I'm so sorry about that. We just wanted to get a sense what our network feels.
Okay.
People were keeping him because of financial gain and was saying that he wants to be discharged. His mood was that he had some psychosocial stressors, but was reported as feeling okay. He actually was having serious difficulties sleeping and was, however, he was eating well. During his admission, he actually had HIV test and hepatitis C, which turns out to be positive. He was put on CLD and INH. I think Dr. Chanda's questions already managed this patient with Dr. Dalal is, would we label this patient as difficult? Dr. Wantula, do you want to take that up? This patient who wants to go home, I must mention he's 28 days into his admission and is still shedding virus. His last swab, the 7th, was actually positive, but has been pushing the staff, I want to go home, I feel fine. Would you label this patient as difficult, Dr. Wantula?
Hi, this is Wantula. Can you get me?
We can't hear you.
Can you get me? Hello?
Yes, we can hear you now.
You can get me now?
Yes.
Yes.
Okay. What was the question again?
Dr. Chanda's question. Would you label this patient as difficult? He wants to go home with a positive swab.
No,
I
wouldn't.
cooperative.
I wouldn't. I would definitely wouldn't label him as difficult. It's also dependent on the amount of information we've given him to understand his current situation and how he's coping with that. So I wouldn't label him as difficult. It's a good opportunity for us to sit down with the client and be able to iron out his current situation. Yeah.
Okay. So Dr. Antula says he wouldn't be labeled as difficult, though by the time I think Dr. Chanda was seeing, people felt because this patient was putting a lot of pressure, so they felt it was difficult. Apologies once again for the sound. We had speaker failure. So why do you think he was refusing treatment? Dr. Katamba, any thoughts?
I think this patient was refusing treatment. He was not ready to take the treatment. He was not mentally prepared to accept the treatment. So it will be good to sit the patient down and make him understand that you do not necessarily have to present all the symptoms for you to be positive to COVID-19. Once he understands that, and he understands that the test that was done is valid and the results are correct, he would be able to be ready to start treatment. So that's what I think. Thank you.
reached out to Dr. Dalal, and they co-managed this patient. Next slide, please. Dr. Chanda.
Yes.
Please go ahead and tell us about, was this patient difficult? Why do you think he was refusing treatment, and what you did?
Okay. So actually, this patient, like I was saying, had been labeled difficult by the previous group, even our group. But upon further discussions with him, we just realized that, like someone rightly pointed out, he didn't have information, and there's a lot of things that he was going through. Then also, for him to refuse the treatment, primarily it was because he was not convinced about the current illness. So the team and I recognized that this is more of a psychological problem than a physical problem. So I reached out to Dr. Dalal, who just gave me a crash course or ran me through psychological first aid, where we emphasize the 3 principles of look, listen, and link. So in our next step, we employed active and empathetic listening, where I went to this patient and just let him speak what he wanted to say. Then, like Dr. Dalal had mentioned earlier, it was not really about giving advice, but letting the patient speak and opening up. Then later on, Dr. Dalal had shown me some grounding techniques that I would apply to calm the patient down, because you have to agree, he had a lot of psychological stresses, the diagnosis of COVID-19, the newly diagnosed HIV and hepatitis B. So he had a lot to do with it. Then couple that with the long duration that he was spending in the isolation facility. So the technique that we employed was a breathing technique, basically which consisted of asking the patient to sit in a comfortable position, then taking 10 long breaths, counting down. This basically centered the patient to his current surroundings. So these plus other techniques, if essentially involving empathetic listening, we started seeing a huge difference in the patient's demeanor towards us and towards the other patients. 3 days later, this patient we had all labeled difficult actually started becoming very cooperative and even started talking more and more about his personal life and the things that he's actually missing. Even the irritability and anxiety also improved. But even though he had done this, at every session that would see him, he would still mention about him wanting to go home, but still he made remarkable improvement. Next slide, please.
I think that's your last slide.
Okay.
I'm still having an echo. I'm sorry about that. I think we'll take comments from the network on Dr. Chanda and Dr. Dalal's intervention. I know we have a lot of chats. Dr. Sivile, do you want to go ahead and just unmute yourself? Yeah, please, unplug one. Dr. Sivile.
Hi, Dr. Foloshi. Can you get?
We can hear you very well.
Yeah, there's a terrible echo that we're getting. Yeah, yeah. I think I've learned a lot from what the colleagues have presented. Yeah, the interventions. Just to add, suppose the epidemic does worsen, and we know that about 80% or so people will be asymptomatic. Probably it's just to the people who are trying to design these different isolation centers, the advice is maybe let's put some kind of recreational spaces I think this is some of the challenges we had at Courtyard, where we had to put some place where these patients can relax and so on, rather than keeping everybody in the room, you know, because as we've all noticed, people are taking long to, to stop the shedding. They shed up to probably 5.
Hi, Dr. Sibi.
6 weeks about there. Yeah, so it's just of the population where they might need some stimulations and so on, other things that could be there. Yeah, I couldn't help but was curious to notice the insomnia and the DTG that the patient was given. I was wondering if there was a relationship there. Yeah, we might have to also look at that in this patient, but I think it does resolve over time, as people know. Yeah. Otherwise, great case and good insight. Thank you.
Hello, this is Kozia here. I thought also I could put some thoughts to what's going on here.
Okay.
Yes, I do appreciate the presentation that Dr. Naeem Dalal has put up and the team, and I think would really appreciate. I think if we would maybe put together the PFA quick course. I think it would be very essential so that we can use it in most of the places that will be opening up. Like Dr. Silia said, most of our patients might be asymptomatic, up to 80%. So that makes us, we really need to put in some work when it comes to offering that kind of psychological care. So I think very important, valuable points that I've shared.
Yes, indeed, Dr. Kozia. Oh, it looks like we have some success with the speaker. Please mute yourself, Dr. Kozia. So I think what Dr. Kozia is just saying, trying to say is that the Ministry of Health will try to engage the psychiatric community and see how we can work around making things better for patients. Because essentially we are keeping them in isolation. Most of them actually don't need any treatment. And Dr. Sivile, I think that was very, very observant of you. He's like, could this be coming from a dolutegravir? We need to remember we have another epidemic going in parallel. It has been with us for a long time. We can actually see a lot of similarities between HIV and COVID. You actually can't see when you even pick up the COVID. There's a lot of stigma associated with it. It's actually quite transmissible. But of course, the mortality is different. Dr. Dalal, do you want to wrap up this case? By the way, Dr. Chanda, thank you so much. For me, that is the epitome of medicine. The fact that you were able to tease out that we now have a mental issue surfacing from somebody that has a disease where we are all thinking we need to ventilate a patient. You know, I feel like you are actually years ahead, because for us in the HIV world, this is something we struggle with. And I know Dr. Katamba, I specifically asked him, we work together on HIV, and I'm sure you heard his answer. Let's tell the patient more about the disease so they can understand more. But Dr. Dalal and Dr. Chanda just told the patient to breathe, and they saw this drastic difference. You want to elaborate more on that, Dr. Dalal?
Thank you, Dr. Sombo. So Dr. Chanda reached out to me through telepsychiatry, because he's all the way in Dola and I'm all the way here in Lusaka. We used the services through telepsychiatry, really. We communicated through WhatsApp. I did a video, I uploaded it. I couldn't send that large of a file onto him through the email, so I uploaded it on Facebook alone, shared it with him. He was able to watch it, tailor it to the Zambian population through my practice. I communicated with my team, and we forwarded this psychological first aid and the various grounding techniques. And it's very good to see that there is an improvement, and this is where the health anxiety comes in. This is what led us to also think about handing out scores of hospital anxiety and depression skills. And this is something that we're working on right now with the team at Levy as well. What Dr. Sivile said is very true. that if the pandemic was to spread further and majority, 8 out of 10 patients are asymptomatic and they are being kept in quarantine or rather isolation for that long, how are they spending their time? Because remember, it's not COVID-19 that is stressing these individuals, it's actually the consequences of COVID-19. So to wrap up, psychological first aid is a tool that can be implemented and that can be used and that can be easily rolled out in the COVID-19 response. And we can use what available resources that we have in our midst here in the country. And this is just one of the many cases that are currently probably taking place. And as highlighted from other colleagues to say, we need to implement things that are evidence-based. And this is why we are also going to make sure that we do carry out surveys and we do start thinking about research and how we can help that. But for me, what I am more passionate about, Dr. Foloshi and the team, is the healthcare workers. I'm very much passionate about and concerned about the healthcare workers because you really need to make sure that your coping skills are up to date as well. You are away from your homes and your shifts are so you take care of yourself. Thank you.
Thank you so much, Dr. Dalal. I see George, please go ahead with your comment. I have unmuted you. George, please go ahead. George Health Center, I get the sense that you are talking, but we actually cannot hear you. So I'll go ahead and mute you. Please type your comment. I know, is it Henry who had his hand up? If you have a comment, please go ahead and unmute yourself.
Hello.
Yes, please. Who is speaking?
This is Dr. Bobo.
Yes, Dr. Bobo.
Sorry, I joined a bit late. I just wanted to find out from Dr. Dalal, the tool that he referred to, does it apply for to children as well? And I wanted to find out the kind of environment that is there right now for children. Do we have toys for them? Are they able to play? Because I understand that all the children that we have at the moment are stable. Thank you.
Thank you, Dr. Bobo. It's nice to hear your voice. Dr. Bobo, so there are other tools that can be used for children. So there's what we call the Strengths and Difficulty Questionnaire. That is something that can be used up to the age of 17. Very simple questions to ask their current understanding of what's happening. That can be used to gauge their perception as well as the stress levels. As for the other part of the question, Dr. Sombo.
Okay, yeah, sure. I think if Levi has joined us or Courtyard, because I know Dr. Masua, who's also working in the facility, did raise a concern, as you have said, the children are stable. What type of an environment are they in? I do not want to be the one to answer that. I don't know if Courtyard, do we have, Courtyard, do you want to comment on that? Because I know as ministry, we started working on it actually on Saturday when Dr. Masua raised concerns. Courtyard, please go ahead and unmute. Kote, if you are with the team there. Sorry. Okay, so I think we've lost them. So I think that's an important thing, Dr. Bobo. Unfortunately, right now, there's really no specific child-friendly services, but we have reached out to one of our partners. I don't want to mention them in case they can't meet the need. We wrote an email and to see if they can at least assist. Of course, it was a very difficult email to write because I said they need toys. Oh my gosh, but that can transmit infection. So I guess we'll think about it later. They need books. Oh my gosh, but that may be a medium of transmission. But we have noted that and we will follow up with our partner. They seemed promising, but thank you. That's I think that's terribly important. Mwale, I will allow you to say something before we allow Dr. Dalal to wrap up.
Good afternoon. Can I be heard?
Very well.
Thank you. Roger Smale from UNICEF Zambia. So thank you. This is the first time I've joined this meeting, but I would want to build on a bit on the question that Dr. Bobo just put forward, and just to indicate that from UNICEF, would be interested to work with the team on the psychosocial rights approach to looking after the children with COVID-19. And that said, I would propose probably you share the request that you made to that other partner so that we see what elements you are considering. Nothing promised, but would be interested to see exactly what you are interested in doing. Thank you.
Thank you so much, Dr. Mwale. I think you can just write us an email because we'll need your contact. And thank you, Dr. Bobo. You've just gotten us more support for these kiddies that are in a very difficult situation. I think he's talked about things like psychosocial support. This is critical. These children will probably remember this for the rest of their lives, and we want to make sure that they come out okay. David Sinjani, I think you had something to say. David Singini.
Thank you, Dr. Sombo. I had a question or maybe a comment related to social stimulation. And I'm actually glad that Dr. Bobo had spoken about it related to the kids. I just wanted to get a sense of how it is in the isolation center, especially for both children and adults. What is there to stimulate them? Because 14 plus days of isolation and not having the usual entertainment that people have, just interacting with people whose faces they can't really appreciate because of the PPEs. What is there for them? Because I believe that could help in actually abating the effect or the anxiety that they're developing while they're in isolation. Thank you.
Okay, thank you so much, David. Unfortunately, we seem to have lost our colleagues from Courtyard. They did join us, maybe when we had the sound issue, and from Levy. I feel this is the question that's best answered by them in the context of what they feel they need. Of course, I have been to both facilities when we're setting up ECHO. That I know is there, but of course, people need more. They need games, and I'm very happy that our network is bringing up these issues, and we have people that can help, like Dr. Mwale. So I think that one I do not want to answer. I'd rather they answer. Unfortunately, we've lost them. They've dropped out. We had Courtyard. However, I had asked somebody to join us who was in quarantine for 14 days, so that we hear what that experience is like, knowing that if you have a tingle in your throat, it may be COVID coming, any fever, any headache, or that you may infect the other people in the household with you. Dr. Tembo, are you still with us? Dr. Simon Tembo? I think we've lost a lot of people, unfortunately. Do you want to read that chat for me, Katonda?
Good afternoon.
Dr. Sombo.
Yes, please. Yes, please, go ahead.
Okay, so I saw a hand from Dr. Bobo. Maybe she still wanted to make another comment,
Okay.
And also there's Willa.
Okay, Willa, please go ahead. Then we'll allow Dr. Bobo. Willa. Okay. Dr. Bobo, you want to go again?
Yes, please. I think the other aspect for children that I didn't talk about is the issue of having a caregiver, somebody they can trust. I'm not very sure, but when I tried to ask about the child in Kabwe, I was told that the child was on her own. So to me, I thought that is something that is not acceptable for a child. So my question, I guess, is that in terms of space for children so that they can have a trusted caregiver by their side, how are we doing? Thanks.
That's a very good question. I feel like I'm not being joined by people that we work with on the COVID-19 response, but the general rule is when a child is being taken in there, this should be done in consultation with the pediatricians because there's a lot of concern about the caregivers. I know the 2-year-old is in there with the family, so it actually makes sense. I'm not aware of the Kabwe case, but I'll say this. I think I will follow up with the team and we can engage the pediatricians even further and see how we can make this admission process better, or maybe keep these children at home. I know we've allowed some of the kids to stay home because we always do things in the best interest of the family. But that is well noted. I think we'll talk via email. I'm sorry, there are people who have audio troubles. So we'll let Dr. Naeem proceed and wrap up for us, and Dr. Chanda as well.
I think this just gives us more room to say that mental health is so broad and we can look at it in so many different populations. A lot of conversations have come about at the end for children. So we can also talk about COVID-19 in children and how the whole holistic treatment approach is going and what are the best practices and how we can improve that as well. A very good proposal and observation said is that they do need parents, and looking at the psychosocial growth of the child, when you look at the principles from psychology, they don't understand logic until they're in their late 8 or 9, you know. So this is very important to make sure, because remember, you're actually going to cause more risk and stress in this child as opposed to helping them. So thank you for bringing that up. In summary, I would just like to say that mental health is real health, and that COVID-19 pandemic has alarming implications for individuals and their social functioning. And take home, it's not the COVID-19 that is necessarily stressing people out, it's the consequences of COVID-19 that is stressing people out. Also for healthcare workers, it has been shown so far that it's not treating the COVID-19, but also the impact of COVID-19 in their personal lives, as well as in their day-to-day lives, that's causing all this overwhelming response. So let's be in a habit to look beyond the medical and physical health that we are giving to our patients, but also look out the psychosocial element of it. And thank you very much for this opportunity.
Thank you so much, Dr. Dalal. Dr. Chanda, would you like to say anything before we end up? I want to acknowledge, I know there's a comment from the palliative care team. We'll reach out to them, and I get the sense that we may need to come back again for a ped psychological care. I know a lot of things have also come up in the pediatrics since our last echo.
Yes.
So we'll definitely be calling upon you. Dr. Chanda, would you like to say something?
Yes, please. So I think we all know that 80% of people who will be affected by COVID-19 who have asymptomatic mild disease. So it's not that these people won't have any problems. The biggest problem that they'll have, like we've seen, are psychological problems. And psychological first aid does work. So even as we strategize on how we go ahead with the COVID-19 fight, let's prioritize psychological first aid, because the greatest number of people who will be affected by this disease will require it. Thank you very much.
Thank you so much, and we appreciate all the great work that you are doing in there. We know that COVID-19 is actually, it's everyone's business.
Yes, and I must say, I'm very impressed and humbled by you reaching out, Dr. Chanda. Thank you so much, and that is the way to go, really. As you said, it's amazing.
Yeah, it's the epitome of medicine, isn't it? The mind first. So thank you so much. We'll be joined next week. We'll either be discussing the clinical features of COVID-19, or we'll be talking about the lessons from China and Italy. We have acknowledged the proposals for further topics, and we'll be looking into it. Thank you, and see you on Monday.